guys already know about thrombopoietin?
The precursor.
Sure. What?
Precursor.
Precursor to what?
Platelets.
Good, to platelet development. And platelet development is driven by what cell in the bone marrow? Good, yep. Okay, good. So, I guess this doesn't work. Oh, there we go. Okay. So, both thrombopoietin and GM-GCSF stimulate the megakaryocytic line to create and stimulate platelet production in the bone marrow. So, not that long ago, actually, since I've been practicing, is when the development of thrombopoietin actually took place and was FDA approved. So it really hasn't been approved for very long.
Bless you.
Bless you. So there are two thrombopoietin receptor agonists that we have available to us on the market. One of them is called romiplastim, and the other one is L-thrombopag. You don't have to worry about the brand names. So what do we use them to treat? So we use them to treat anybody that has low platelets for a reason. Well, let me actually flip that question. So why do you think that we would use thrombopoietin? So there's the indications are up there, but
Destruction of bone marrow. So there's some kind of bone marrow stuff going on, and your platelets aren't being released.
okay, so a decrease in quantitative numbers of platelets due to a lack of production in the actual bone marrow,
Yes.
right? So it's not really going to help us if there's an issue with sequestration of the platelets, generally. So if we're having sequestration of the platelets, meaning they go into circulation, they're produced in the bone marrow, and then what sequesters them, Tarika? What's that? Mm-hmm. No? So collagen is the factor that becomes exposed that actually starts the whole, platelet activation and aggregation, right? But what actually sequesters platelets, meaning takes platelets out of circulation along with a lot of other cells, right? This thing that does this takes any cell out of circulation that is seen as a problem, or sometimes autoimmune conditions can cause this to happen. Macrophages where? What tissue? Yes, the spleen. In the spleen. Okay, so if it's a problem with the platelets being pulled out of circulation early, using a thrombopoietic agent is probably not going to help us as much as if it's a problem with production. Right, so if we can increase the production in the bone marrow, let's say there's less megakaryocytes in the bone marrow due to something like aplastic anemia or ITP, that can help actually produce increased numbers of platelets. So the mechanism of action, that there's an actual thrombopoietin receptor agonist that increases platelet production in the bone marrow. So how do we give this? So romiplastim was the first thrombopoietic agent that was developed, and it was given, or it is given subcutaneously on a weekly basis. And then L-thrombopag was released just probably 5 or so years ago, can be used actually orally, which is great for patients, and insurance companies like the oral option better because it saves them money. They don't have to go into the infusion center for the injection on a weekly basis. And then you can increase the dose of the L-thrombopag based off of the result that you're trying to get to. So if you're trying to increase the platelet count and the platelet count hasn't increased to the goal, you can increase in increments of 25 milligrams every couple of weeks to try to get to your goal platelet. So who can we not use this in? So anyone that already has risk factors for clotting. So can you guys think of some things that would put you at risk for clotting?
Cancer.
Okay, so cancer. Well, pulmonary embolism is a clot, right? So the question really is who's at risk for something like a pulmonary embolism or a venothromboembolism?
TBT.
Okay, so post-surgery, immobility.
Somebody was just, in bed all day.
Okay, what else? So atherosclerosis for, depending on, so we're talking about thromboembolic disease or thrombotic disease. So atherosclerosis is not really a risk factor, so to speak, for thrombosis. It's a risk factor for plaque rupture, right, or chronic lack of vascular flow, but not particularly thrombotic events specifically. But what about thromboembolic events? What does that mean? What's an embolic event?
Like an embolism, like
Blockage.
dislodged.
Right, so a clot somewhere that then breaks off, right, and embolizes. So where does that generally happen? So what's the most common cause of a thromboembolism to the brain? To the brain.
The brain. It's gotta be arterial.
Yeah.
Good question.
Oh, okay. So
It's arterial side. So.
Big cause of stroke.
Hypertension.
Yes, atrial fibrillation, right? So if the patient has atrial fibrillation and a clot has formed in the atria, right, particularly what atria?
Left.
The left atria, right? So if a patient has atrial fibrillation that is poorly controlled, right, that would be a contraindication to using this. If the patient has history of having thromboembolism, like a venous thromboembolism, DVT, pulmonary embolus, arterial thrombosis, that would be contraindications. So why would those be contraindications to using thrombopoietin?
Because you're going to increase their clotting.
So you're increasing their platelets, right, which is part of the clotting, right? So obviously, if you're increasing the number of platelets that are available and they're already hypercoagulable for whatever reason, that could increase their risk of developing a thrombosis, right? Okay.
Question from Kate.
Yeah.
Will also pills be a contraindication?
Would what?
Will oral contraceptive pills be a contraindication?
Well, so not all oral contraceptives have the risk for venous thromboembolism. What kind of oral contraceptives carry that risk? That's right. So estrogen containing. So somebody that's just on an estrogen containing, medication, not necessarily, but if they've been on an estrogen containing medication or even an estrogen receptor modulator, like for breast cancer, and they've had a clot already, then absolutely. So I would say that that's a relative risk associated with using this drug in somebody. And maybe given that relative risk, if there's another thing that you're thinking could put them at risk for a clot, maybe you change their oral contraceptive, right, to something else that would have lower risk, like a progesterone drug, right? Good. Yes. All right, so potential side effects. So after discontinuation, those receptors that we're targeting or agonizing, sometimes thereafter, the megakaryocytes get even lazier than they were before, so you can have worsening thrombocytopenia and, of course, risk of bleeding. And then with L-thrombopag, you can have hepatotoxicity. Also, there is stimulation of reticulin fiber formation in the bone marrow by thrombopoietin is a known side effect. And so what reticulin is almost think of it as a fibrous deposition in the bone marrow that then no longer allows for normal hematopoiesis. So it's almost like if you think about when we looked under the microscope at the bone marrow slides in lab, right, you saw a lot of fat globules, but in between that you saw pockets of cells. What happens is this reticulin fiber starts to deposit in the bone marrow, and that crowds out the ability for normal hematopoiesis to happen. So using this long term, we don't really know the side effects of using this drug long term because we haven't had it for that long, but that's certainly a concern. All right, any questions? Yeah.
That is so
How do
cool.
they make those?
You're like, I need to make those.
All right.
Is it gelatin?
I don't know. I just found that picture. That was cool. Okay, we're going to move on to, we're going to totally switch gears, and we're going to move on to anemia.